And here we go. Just a second. Can you hear me clearly? Can you hear me? You cannot hear me. Well, you can. Oh, it's breaking. Okay, let's see. What about now? Can you hear me clearly? Excellent, good. So let's start this. Well, let's keep going with the acid-base disturbances, shall we? Let's see. So here it is. So, respiratory acidosis, we spoke about the airway obstruction, the acute lung disease, chronic lung disease like COPD, for example, opioid and sedatives because of the inhibition of the respiratory centers and weakening of the respiratory muscle. Except myasthenia gravis and Lambert-Eaton, what other disease can lead to weakening of the respiratory muscle, guys? What do you think? What other disease can lead to respiratory center weakness? Excellent. Coma. Yes, it's coma because people in coma have atrophying of their muscles, which lead to them becoming like their muscles become much less functional. There's secondary respiratory muscles, and that will lead to them get respiratory acidosis. Okay. So the bicarbonate, in the other hand, bicarbonate disturbance, which when it is really low, that can lead to metabolic acidosis. Yeah, so the patients with metabolic acidosis, let's speak about these. This is the most important thing about the pH disbalance because it's the most commonly asked one. Why? Because of the anion gap. You're like, anion what? Anion gap. So what is this? Well, basically they discovered the following. If you check your highest ions inside of the blood, which is the sodium, can somebody tell me what is the normal level of sodium in your body? How much is a normal level of sodium in your body? Around how much? Well, when 125, it's hyponatremia, so it needs to be 135 until 145, okay? So, basically, they were like, if you calculate the sodium level, which is one form of electrolyte, and you minus it from the major electrolyte, which are chloride and bicarb. You know, chloride is around 100 something, like 100 actually, and bicarb is around 20, yeah? Like 20, 22, something like this. If you minus these numbers, I mean the bicarb and the chloride, from the sodium, you will have what? You will have some number left. So what is this number? It's the number of the minor electrolytes that you did not check. And it's normally must be like between 8 and 12. So a normal bicarb. Okay, what's up with this breaking thing? So, okay. Somebody is asking how much is bicarbonate normally. A normal bicarbonate must be around 24, okay? Around 24. Just remember it, 24, 44. The gas is lighter, so it goes up. So the CO2 is the 44. Okay. So how to remember which one goes where? We have sodium chloride and bicarb. How do you remember which one goes first? So the positive minus the negatives. The only positive electrolyte here is sodium. The other twos are negative, and thus they come afterward. Okay. So if we speak about the anion gap, we have normal ion gap to be between 8 and 12, which is basically some electrolyte that you could not check, like magnesium, for example, you know? For like phosphate, they are really low numbers, so you don't actually check for them, so you don't put them inside of the formula. But if the number was like 20, that's high, so you are like, okay, normal anion gap is until 12. What about the other 8? This is a foreign substance, okay? okay? Some substance from the outside of the body. Okay, let's speak about, first of all, an increased anion gap. So an increased anion gap lead to the patient will have the following. Sadly, you must memorize these two mnemonics, the mud biles and the hard ass. Just memorize them, at least the mud biles. If you don't want to memorize this one, it's okay, but the mud biles you must. So the first one is methanol. Guys, we have methanol, ethanol, and propenyl glycol and ethanyl glycol. Yep. Due to acidic molecules that are foreign from the body in case of increased anion gap metabolic acidosis. Okay, so if speaking about the methanol versus the ethanol versus the ethanyl glycol, where can I find methanol? What's up with this breaking? Where can I find methanol? Methanol is found in what? What form of alcohol? Antiseptics, exactly. So antiseptics have methanols inside of it. Well, what about like the alcohol that people drink? Is it methanol or ethanol? Ethanol. The thing that people drink, it's ethanol. What about ethylene glycol? Where can I find this? The antifreeze for cars, guys. So, you know this, there is something called the antifreeze. So this antifreeze, I must use for this freaking conversation. I keep it breaking. So this freezing liquid, it's blue. And it smells sweet. And conveniently, it is around in a lot of people's garage. So who drinks it? Two types of people, children and alcoholics. Okay? Yep, alcoholics and children. They love to drink it. Well, you are like, okay, so you have three types of alcohol. Why I told you about them? Because each one of them has different symptoms. If you drink methanol, you will have a blindness. It makes you blind, okay? Why? It destroys your retina. To make it worse, methanol blindness is irreversible. If you go blind from methanol, you will not see again. Well, what about the ethanyl glycol, the antifreeze? Well, ethanyl glycol can lead to two problems. Conveniently, both of them are in the kidney. One of them is acute tubular necrosis, which means basically that your tubules are getting destroyed. The other one is, formation of stones, okay? It can lead to kidney stones. So, ethanyl glycol can destroy your kidney, while methanol can destroy your eyes. Okay, so methanol, it makes a substance called formic acid, and that actually destroys your eyes. And I will tell you more about it when we speak about biochemistry. In case of uremia, do you have uremia due to liver dysfunction or due to kidney dysfunction? Excellent, kidney. Well, in case of liver dysfunction, will you have hyperuremia or hyperammonemia? Ammonia. If they ask you why, remember and keep in mind that the urea cycle is located inside of your kidney. Yeah, so if the urea cycle is inside of your kidney, the function of urea cycle is to get ammonia in and get what out? What we used to get out? Urea. So if the liver is destroyed, you will not get ammonia in, you will not get urea out, so you will have hyperammonemia. After the urea gets out, it gets cleared outside of your body by the kidney. So if you have a kidney dysfunction, you will have hyperuremia as well. Okay, so that was uremia. The next one is diabetic ketoacidosis, DKA. In case of DKA, which is diabetic ketoacidosis, first of all, does it happen in type 1 or type 2 diabetes? Type 1 diabetes, excellent. Type 1 diabetes happen in old people or young people? The young one, yes, excellent. And if we speak about the diabetic ketoacidosis, um, what is leading to the acidosis? Let me try to trick you. What is leading to the acidosis? Is it the ketones body or the glucose? The ketones body, which there is many of them with weird names that has acetone in the name. Okay? So it's the ketones body, not the glucose. Okay, so that's in case of DKA. Except of DKA, what other disease can lead to presence of ketones body inside of your urine? Starvation is one. What else? Okay, alcoholism is one, and the third one is pregnancy. Okay, remember, in case of a pregnancy, if they get a preeclampsia, they can have ketones body in their urine as well. Okay, the next one is the propylene glycol. This one confused me, and I had to look it up to check where the hell do we use this propylene glycol in. Apparently, it's used in factories and something for the nails, guys. You know this stuff that ladies use to clean their nails from the manicure? Yeah, it's like acetone, but not exactly acetone. They say acetone, but it's not acetone. Some of these products that are used to clean the nails are made from a propylene glycol. Also, some of these substances that used for in chemical factories. So if you have a patient coming from a chemical factories, or he's drinking this thing for the nails, like the acetone for the nails, exactly, but it's a different type of polish of the nails. Yeah, so that's where you find the propylene glycol. The other one is iron tablets. Guys, do you know if you have a patient who swallow a lot of iron tablets, can you see them on an x-ray? Yeah, it's awesome actually. Take a look. So you can see this mass that is, basically hyperlucent. And the reason it's hyperlucent because it contains iron. So this patient has consumed a lot of iron pills. Well, why he consumed a lot of iron pills? Is he trying to become Iron Man? No, it's a suicide. Yeah, he's trying to kill himself. It's really stupid because he will not kill himself. He will just get a freaking ulcer and come with a really horrible pain to the doctor. So, next one. Guys, is it for everybody the sound is breaking? Well, we have to check that problem. It's not normal. Okay, if it happens again, please inform me. I can log out and look back in. Okay, so it happens again? Seriously? Okay, let me log out and come back in. Just a second. Okay, can you hear me now, guys? Okay, excellent. Good. So back to this, we have the other one is isoniazid, which is an anti-tuberculosis drug, can lead to acidosis. Lactic acidosis, for example, someone who was running or someone who has von Wieren's disease, which is a glycogen storage disease. Also, lactic acidosis can happen after using a lot of anti-diabetic drug like metformin. Also, it can occur with HIV drugs. So all of these are super important. Well, the lactic acidosis, does it happen due to anaerobic glycolysis or aerobic glycolysis? The anaerobic glycolysis, excellent. Well, the next one is ethylene glycol. We spoke about it. It was the antifreeze. It contains the oxalic acid, which is important because this guy make you the kidney stones. Okay, and the salicylate. They rate right next to it late. So, first of all, what is salicylate? Can someone tell me what is salicylate? Yep, exactly, it's aspirin. So when aspirin is metabolized, guys, it becomes another substance. And so there is some tree called womb tree, okay? Someone can correct me in English. I forgot what is the exact name of this tree. I think it's womb tree, but I'm not 100% sure. So anyway, this tree, basically from its root, you can get the aspirin. And that's what the old Egyptians did actually. They got the aspirin from the roots of the womb tree. And after getting this aspirin, what they did, that they give it to the people. Willow tree. Yeah, exactly. So the willow tree. And this willow tree, basically, they get the root, they boil it, they get an extract out of it, they give it to the patient, inhibition of cyclooxygenase, no pain. Magic drug. That's why this tree is really famous even in a lot of people who do meditation. They say, well, go meditate under the tree of life and your pains will go away. Yeah, because it has aspirin inside of it. Yep. Okay, so the next one, it can give you an ulcer as well. So that's salicylate. But why they write late? Well, salicylate is salicylic acid, yes? So salicylic acid can lead to an increased anion gap metabolic acidosis, but this is late. So what is the early? Well, salicylate as well can activate your respiratory center directly inside of your brain. So that will lead to respiratory acidosis. Yeah? So, why this is important? Because this is the actual use for the winter formula. So guys, tell me please. Someone who consumed aspirin, he has metabolic acidosis and he has a concurrent respiratory alkalosis. If I predict a number using the winter formula, will his BCO2 be higher than that number or lower than that number? Think about it before you answer. I will give you a minute to think about it. So the question again, someone taking salicylic acid, you know that it basically aspirin. You know that these patients have metabolic acidosis, also they have respiratory alkalosis. So two pathologies, not one. So what will happen to their, you calculate the winter formula for these guys to see the prediction of the BCO2. After you saw that prediction, you want to check the real deal, and you see the real deal. So I'm telling you to compare the real deal to the prediction. Yeah, it's mixed. Obviously, it's mixed, but that one is alkalosis, and this one, like he has metabolic acidosis and respiratory alkalosis. So let's take a look what happens. So his prediction for the BCO2, he has what? He has a case of acidosis. So if you have a metabolic acidosis, what happens to your HCO3? It will go down. Yes, obviously it will go down. So it will go down, so your BCO2 will obviously be down. But when you have a concurrent respiratory alkalosis, what does respiratory alkalosis do for you? Respiratory alkalosis, what it does for your BCO2? It decreases your BCO2, yeah? Decreases BCO2, you are blowing it away, yeah? So you get respiratory alkalosis when you blow away all of this BCO2. Okay, so initially, let's imagine that the predicted number, I don't know, let's say it was 25. Well, after the reality, when you do it, do you think it will be more than 25 or lower than 25? It will be much lower than 25 because you are blowing all of that PCO2 out, okay? So it will be like 14. So as you see, the prediction was much higher than the measured PCO2, which means measured PCO2 is less than the predicted CO2, which means the patient has a concomitant respiratory alkalosis. Yeah? So 2 in 1. Okay, so the next thing. These are done. All of the increased anion gap are done. Now we speak about the normal anion gap. Normal anion gap are the hard ass. Basically what you must know, it's a problem in the molecule hydrogen. That's it. There is no other problem. So if we speak about the hydrogen, there is hyperchloremia, hyperelimination. Well, you're like, what the hell? What is hyperelimination? Can someone tell me what is hyperelimination, by the way? Hyperelimination. It's a polite way to say what? Come on. Well, okay, well, actually you need to be careful. That's the thing. When you hear the word hyperelimination, you think it's too much stool, but it's not too much stool. It's basically, have you ever heard of total parenteral therapy, in which you get all of your nutrition, and instead of getting it like through your mouth, you are getting it through your veins, okay? So this, we call it like total parenteral nutrition. So this TBN, yeah, we use it in a premature baby, that's correct. So this TBN elimination, yeah, it's basically, yeah, see, total parenteral therapy, also known as parenteral hyperelimination. So be careful, it's this one, not the other one, okay? So what the hell, why this is related? Well, you guys are kind of correct. So if you are giving all of the treatment through your veins, whatever you are pooping out, you are not recompensating for it. So you will get a lot of bicarb outside of your body, yeah? And when you get a lot of bicarb outside of the body, you are only getting bicarb outside. You are not getting any other electrolyte outside. You are not getting bicarb inside as well, because it gets reabsorbed from the intestine. It's not. So if that is the deal, you will get a metabolic acidosis, but your pH will not be affected because you do not have a foreign particle that is accumulating inside of your body. Well, Addison disease is speaking about which problem? Addison disease is a pathology of which organ? It's a pathology of the adrenal gland. Excellent. So it's a pathology of the adrenal gland. Basically, adrenal insufficiency. The most common cause is autoimmune disease. The second most common cause in developing countries is TB. Yeah? Okay. And if we speak about Addison disease, it's an insufficiency of your adrenal gland. So let's think about it. If your adrenal gland are not working, due to the feedback mechanism, what happens to your ACTH? It becomes really increased. So remember, ACTH comes from a family of hormones. He does not come alone. He comes from a family called the preobiomelanocortin. Okay? It's really difficult to write it. Preobiomelanocortin. Okay? So this family, when the ACTH is high, all of these will be high. The opioid, well, intrinsic opioid, like your endorphins. melano, so that's melanin, which gives the color of the human body, and the cortin, which is the ACTH. So all of these three will be high in a patient with Addison disease. Anyway, Addison disease, so as you said, guys, no aldosterone. If you have no aldosterone, what will happen to the reabsorption of the sodium? It will go up or down. Reabsorption of sodium up or down in case of insufficiency of aldosterone. It goes down. Excellent. What about reabsorption of hydrogen? Potassium. More potassium reabsorption. You are correct. Well, who likes potassium? Hydrogen. So hydrogen and potassium are having a love story. So in case of Addison disease. So when you have more hydrogen inside of your body, you will get normal anion gap metabolic acidosis. Why? Because the disturbance is hydrogen, not a foreign particle. So the next one is renal tubular acidosis. Do not worry a lot about this. I will be speaking a lot about them in a minute after we finish this one. So the next one is actually diarrhea. Why? Because diarrhea contains a lot of bicarb. And basically, I like, oh, this is true. G.F. Kennedy actually did have Addison disease. It was kind of like a scandal. I don't know why, but it was kind of a scandal that John Kennedy had Addison disease. Well, he did not die from it. He died from something else. So, diarrhea. So diarrhea contains a lot of bicarb. And when the bicarb goes outside of your body, well, you will have a state of acidosis, because bicarb, we said, it's an alkaline molecule and you are losing it. Acetazolamide, it's a diuretic that inhibits the carbonic anhydrase in your tubules, and we'll speak about it like in the diuretic chapter. And that can, in which one? Well, look, the anion gap can only be manipulated by foreign particles. If it is a particle inside of your body, it will not be manipulated with. A common question would be like, yeah, but hydrogen is super high. Why it's not affecting? Well, hydrogen is a big molecule or a small molecule. It's only one H that has one electron. It's a small one. So it will be able to pass intracellularly, extracellularly, all over the place. So it will not actually alter a lot your anion gap. An ion gap is basically a big molecule that you cannot move anywhere, and they are from the outside of your body. How much? How much it should be normally? It should be normally between 8 to 12. Some book write 8 to 16. But in the real exam, if they want to give you a high anion gap, don't worry about it. They will give it to you to be really high, you know? So you will not even, it will not be in this range. It will be like 25, 30, something like this. So spironolactone, it's also called potassium sparing diuretics. So what happens to the potassium inside of your body? Potassium sparing diuretics. What happens to the potassium inside of your body? It says potassium sparing. It spares potassium. It does not allow it to get out. So it will increase. So when it increases inside of your body, what potassium like? Okay, and that will lead, it likes protons, it likes hydrogen, and that leads also to normal ion gap metabolic acidosis. Finally, saline infusion, and the exact mechanism in which it happens we'll speak about in endocrinology because it's kind of long. But there is one more concept I would like to tell you about. There is something called the pKa. Just not to make it less confusing than it is, if you have a state of acidosis, your pKa will be low. If you have a state of alkalosis, your pKa will be high. That's it. I don't want you to know anything else about it. If your pKa is low, you have acidosis. If your pKa is high, you have alkalosis. Exactly like the pH, okay? if you see it. I'm not sure that you will see it. I did not see it in New World or in the Real Deal, but some person put it on the NBMEs, like the old forms. I mean, like form maybe 13 or 12, something like this. So you might see it, and I don't want you to get scared. So the pKa, it exactly means something like the pH. So if it's high, it means you have a state of alkalosis. If it's low, you have acidosis. Okay, so why do we give acetazolamide? I guess you are asking about acetazolamide for someone who's climbing mountain. Well, acetazolamide itself, it leads to normal anion gap metabolic acidosis, correct? And people who climbs to high mountains, they have low O2 in the air, correct? If you have low O2 in the air, what you will start doing? You will start to hyperventilate, yeah? You are like, cool, I'm hyperventilating. That sounds like a good idea. Well, yeah, when you are hyperventilating, what are you kicking out? What is going outside of your body? BCO2. So you get acidosis or alkalosis? Respiratory alkalosis. Excellent. So you want to compensate for it by creating a metabolic acidosis. How to create it? With a drug? Which drug can lead to metabolic acidosis without killing you? Acetazolamide. Excellent. So you answered it. Good. So we are done with acidemia. Let's speak a little bit about the alkalosis chapter. So the alkalosis chapter is actually really interesting. So alkalosis, we have respiratory alkalosis. You are welcome. We have respiratory alkalosis and we have metabolic alkalosis. If we speak about the respiratory alkalosis, it is always due to hyperventilation. So I have my step 1 exam. I'm going to sit on the barometric center. I'm sitting down. I start hyperventilating. Well, they used to tell us back in the time, take what? A paper bag and breathe into it. Why? That increases your CO2, which decreases the risk for you to get respiratory alkalosis. Thus, your anxiety goes away. And to make the matter worse, when you are hyperventilating because of anxiety, you cannot know it. You don't know it. You don't realize it. Someone around you should tell you, man, you are hyperventilating. Take a bag. Or just wear your mask. It works as effective. So, the next one is hypoxemia. Well, somebody said about the high altitude, the climbers, someone who's climbing to Mount Everest. So when he climbs to Mount Everest, he has less air. He start hyperventilating. He get CO2 kicked out, and he has to recompensate for it. The next one is salicylate. Early, what does that mean? Well, the salicylic acid causes two things. It causes respiratory alkalosis because it affects your respiratory center directly in your brainstem, leading you to hyperventilate. It also can, later in the time, affect, it is itself an acid, and it's a big molecule. So it can lead to an increased anion gap metabolic acidosis. And if you remember in the mud biles, it was the S, the last S. Yes. Okay, so the next thing is a tumor. Why the hell do you think a tumor will make you hyperventilate? Well, I think it depends on the location. Some tumor location can lead you to hyperventilate. One more thing that we'll speak about today in tumor, that tumors themselves secrete some substances that can lead you to hyperventilate when they lyse. Okay? The last one is pulmonary embolism. Why a pulmonary embolism will make you hyperventilate? Well, a pulmonary embolism will lead to hypoxemia. Why? Because, look, this is an alveole. And this is an alveole. And this is your blood vessel. Just imagine it to be a blood vessel. And next, you have here what? You have the BE. After having the BE here, there is less oxygenation, less basically exchange of O2. If you have less exchange of your O2, you get hypoxemia. When you have hypoxemia, who will sense that? Your aortic and carotid chemoreceptors, if you remember this. Can someone tell me the carotid chemoreceptor is connected with which cranial nerve? Is it vagus or glossopharyngeus? Come on, I asked about the carotid one. No, it's not vagus. Come on, guys. Remember, the vagus was connected to the aortic one. Okay? And if we speak about the glossopharyngeus, it was connected to the carotid one. Yeah? I told you it's really common mistake. They do put it on the exam. Glossopharyngeal nerve connect your common carotid sinus, while your aortic arch is connected with vagus. Do not make that mistake. Okay, so you have hypoxemia, you get tachypnea, and that lead to respiratory alkalosis. Why? Because you kick out a lot of CO2. I did? I'm sorry, I asked about the carotid. I said carotid. I'm British. Oh, I'm really sorry if I said that. So carotid is glossopharyngeus. If I said aortic, you are right, it's vagus. Good. Okay, metabolic alkalosis. So, in case of metabolic alkalosis, it goes something like this. The disturbances mainly in the kidney, not in the lung. And it can be due to diuretics, like loop diuretic, for example. Also vomiting. Why vomiting? Well, when someone is vomiting, what is he losing? Or force vomit, for example, bulimic or anorexic, what is he losing? Yes, HCl, H and Cl. So when you are losing the H, you are getting what? A state of metabolic alkalosis. Yep. So vomiting. What else do you lose in case of vomiting? Except HCl. Many electrolytes, including potassium. Excellent, potassium. They love to ask about potassium. Yep, because it can lead to arrhythmia. Okay, good. So, vomiting, antacid use. So, antacids also can lead to you to lose some hydrogen. Why? Because they get chelated by the antacid. And hyperaldosteronism. Why? What does hyperaldosteronism kick outside of your body? What do they kick outside? High aldosterone level. Potassium, correct. And when the potassium get kicked outside, what get kicked outside with him? Hydrogen. So you get in a state of metabolic alkalosis. Done. Excellent. Guys, there is one more note I want you to be really careful about, because it's not in first aid. I added it, and I want you to add it as well. Okay? It's this one. If you have a patient with metabolic alkalosis, okay, and they ask you what is the next step of management, I know that this sounds like step 2, but it is asked on step 1. So you must know it in step 1 as well. If they ask you what to do next for this patient, you must check his urine chloride, okay? So you check his urine chloride. That's your next job. Why? Because, well, diuretics, for example, if you are using some form of diuretics lead to low amount of urine chloride. But if it was due to some hormonal problem, your urine chloride will be really high. And this is also important, because if you have low urine chloride, that means you can correct this disease with giving normal saline. But if you have a high urine chloride, that means this disease cannot be corrected with normal saline. So you must check the chloride concentration in the urine in a patient with metabolic alkalosis. Please know this one. Okay, so let me just, of course I will explain it again, but just a sec. Okay. Okay, so the next thing about metabolic acid, well, you have a patient with metabolic alkalosis. If you have metabolic alkalosis, remember it's alkalosis, so your pH is higher than 7.45, yeah? And if you have an alkalosis and it's metabolic problem in the kidney, so it's a problem in the bicarb. Bicarb will be high, so it will be more than 24. Well, okay, we have a patient with a bicarb more than 24. What to do with him? And he is clearly has metabolic alkalosis. You must know why it happened. So your next step is to check his urine chloride. If his urine chloride was low, okay, it's low, that means this disease is saline responsive, which means if you give him normal saline, his problem goes away. So it's probably due to vomiting or losing gastric acid or losing a lot of fluid from his kidney through the use of diuretics. But if he was vice versa, he has a high urine chloride, you need to think about other problems, not diuretics. Well, it could be something that acts like a diuretic, but it's not a diuretic, which is like Bartter and Gittelman syndrome, for example. Or it can be like a hormonal disbalance, like primary hyperaldosteronism, Cushing disease, or ectopic ACTH production, which is saline unresponsive. Actually, what the question comes for you is just what you must do. What you must do, of course I can, but can someone give me an idea? Because I'm really a newbie. I have no idea how to take a screenshot in a MacBook. How can I do that? Somebody write me. I really have no idea. Command, Shift, and 3. Wow. Okay, thank you. Good. Command, Shift, and 3. Wow. Okay. Thank you so much. So, okay. So what they ask you to do is to check the urine, the urine chloride. That's your next step. Okay. So the next thing we are going to speak about now is this guy. They do give you this one, but since it's in first aid, let me give you the more complicated one. And then we can take a look at this if you want. So let's take a look at the more complicated one. Because if you can deal with the more complicated one, that one will be a piece of cake. So normally your pH is around like 7.35 until 7.45. So it's somewhere right here, near the normal. Your arterial plasma bicarbonate must be also in case of normal range, it's in its 20, like between 24 to 28, something like here. And your PCO2 must normally be how much? It should be like around 40s, as you can see here. So if we say someone has, let's start with something simple. The patient is suffering from metabolic acidosis. Metabolic acidosis. What will happen to his pH? He has an acidosis. What happens to the pH? If you have an acidosis, your pH goes down. If you have an alkalosis, your pH goes up. Okay? So, in acidosis, pH will be down. In alkalosis, pH will go up. Okay? So, let me show you this. Okay, so if we have this patient right now, and he has a metabolic acidosis, so his pH will be low, obviously, less than 7.35. Okay, he has a metabolic acidosis. Since it's a metabolic acidosis, the problem is it in the kidney or in the lung? The kidney. Yes, it's metabolic, so the problem is in the kidney. So the primary pathology will be in the kidney. Okay, so if it's in the kidney, the primary pathology will be in the PCO2 or it will be in the bicarbonate? Yes, it will be in the bicarbonate. Excellent. So the bicarbonate, will it be high or low in case of metabolic acidosis? Remember, it's an alkaline molecule. Yep, it will be low. It will be really low. So it will be lower than 20. So we can go to this area. We already have the answer, but let's keep going. So if you have a metabolic acidosis, your lung would like to kick out that BaCO2 or would like to keep it in. You are in a state of acidosis and you must compensate for it. Yes, it would like to kick it out. Yeah. So you want to kick it out, so you are moving downward, as you can see. So it must be like within this area, yeah? And to close all of it away, you are stuck to this area. See? And that's metabolic acidosis. It's the fan shape. Metabolic alkalosis, on the other hand, what happens to your pH? Will it be high or low in metabolic alkalosis? Metabolic alkalosis will lead to high pH. Excellent. So in case of metabolic alkalosis, the pH will be high. And if we speak about the bicarbonate, will it be high or low? See, it's ridiculously high here. It's more than 44. Normally it was between 24 to 28. Okay. And as a compensation, if you have a metabolic alkalosis, you have a lot of alkaline. Would you like to have more acid to compensate for it or more alkaline to compensate for it? Yeah, you want a more acid. And to get more acid, you need to do hypoventilation, which will lead to accumulation of this guy. Hypoventilate, not hyperventilate. Hyperventilate will kick the acid out. Hypoventilation will lead to more acid inside of your body. Okay, so let's take a look. One more for the team. Let's take acute respiratory. Of course I can. Well, somebody said shift command and number 3. I like this. Nice. Okay. Okay, so the next one goes something like this. We'll try it in the future. Actually, let's do it now. 4, Control Shift. Oh. Okay. Wow, that was cool. Okay, good. So here we go. The next one goes something like this. Chronic respiratory acidosis. Chronic respiratory, well, let's start with the acute first. If you have an acute respiratory acidosis, acidosis. If you have an acidosis, your pH will go down or up? Down, exactly, it will go down. So when your pH is down, you will have an acidosis. So if it's metabolic, so your bicarb will go down or up? Down as well. Yep, it will go down. So to compensate for it, it's acute respiratory acidosis. So what should compensate for it? Which organ? Well, in acute respiratory acidosis, the lung should be, but it's acute. Acute respiratory acid. Oh, did I ask about? Wow, I have this problem in my memory. Okay, so I think I asked about acute respiratory acidosis, yeah? So if I ask about acute respiratory acidosis, the compensation need to be from the kidney. But the kidney is super slow, okay? So since she is super slow, you will be waiting for response from her, but no, she will not have a response yet. Why? Because she has a delayed mechanism, so there will be no change in the bicarb yet. See, the bicarb is normal in case of respiratory acidosis, acute one. But in the chronic one, the kidney woke up, drank its coffee, and now started to work. So the bicarb has went up in case of chronic respiratory acidosis, okay? Okay, let's go down to this area. Oh, actually, guys, you deserve a little break now. We finished the acid base. This topic is kind of difficult. There is a lot to know. To know. I agree. No. We did not finish yet. We have one more hour, one more session. I will do this and a little bit of neoplasia. Okay, so 1 more hour after the 9 minutes break. Okay,